Hi, everyone. Want to welcome you to this week's episode of VBC One Take. In studio, we have some guests with us from Lilac. I want to introduce you to Marc and Neetu, and I'm going to give them a moment to talk a little bit about their background and role at Lilac. Marc, you want to kick us off?
Oh, sure. Great. Shannon, it's great to be with you. And I'm glad to be here on with Neetu. We have three co-founders of Lilac. Neetu's the CEO. I'm the Chief Solutions Officer, and Alex Schaefer is our Chief Commercial Officer. And I'll just give you my background. I'll let Neetu give you a feel for the company overall. I have a lot of experience in government healthcare as well as at health plans. And I also was a founding executive in a company called MedHawk or MHK. It is a payer platform. And so spent a good dozen or so years there, was hankering to do another startup. And Neetu and I met through a mutual friend. And we both were talking about the need to really have plans and delegated payers to have the right data. And that's really what we're doing, but I'll turn it over to Neetu.
Thank you, Marc. It's great to be here, Shannon. Thank you for having us. I've spent my whole career building software, so I'm very much a techie. We at Lilac Software, we're focused on fixing the data fragmentation problems that plans and delegated payers have, and then using that data to drive insights, automation, AI, workflow automation, using agents to drive workflows and complete tasks. So primarily focused on making sure there is data in good quality that can help drive operational excellence and also at a cost-effective manner using AI.
Awesome. Me too. We had an opportunity to meet a couple of times in preparation for our conversation today. And I think one of the things that really impressed me about you and why I enjoyed our conversation so much, and with Marc too, is your experience. You guys, you're not and this isn't to dismiss startups, but you're not a tech person first necessarily. You have experience working at health plans and knowing the struggles that they go through and the challenges that they have and getting that data just right. And there's been a lot of changes in our industry of late, especially around quality. And so I was hoping that maybe we could start there and talk a little bit about what you're seeing in the industry, how you're thinking about it at Lilac, and recommendations maybe that you're giving to others that you're speaking with in the fields.
Yeah, all of us at Lilac have come to Lilac having lived like multiple careers in our lives in the past. And the choice to build Lilac is actually a very intentional and mission-driven one. And we all are driven to bring something into the world that is actually making it better. And given our skill sets, that is the thing that motivates us right now. How can we help plans function better so that if they function better, members are going to experience a better outcome? And that is always good for everyone. In terms of quality, this is quality in stars. This is very close to our heart for all of those reasons. It combines the need for data being in the right place at the right time and in good quality. It combines actually calculating and measuring the progress that plans are making with members, and then helping them point out exactly where what is needed, which member needs what help. So stars and quality is all about taking care of members, and it requires all of those other pieces that Lilac brings in terms of data, NCQA certified measures, PQA licensed measures, clear indication of where the gaps are, and then help with agents to outreach to members to close those gaps. And I think all of that combined, like not only is like a great tech solution that can be used, but it in fact drives outcomes, which is very, very motivating to all of us.
Yeah. And just to add a couple of things here, I think too many people think of the quality programs in healthcare as sort of nuisances, but they are very intentional. You can take a given measure and say, this is just busy work, right? But if you really take the programs holistically, they really are meant to improve quality, which reduces costs. And I think there's a lot of great examples of that, whether it's in the STAR program in MA or in the emerging Medicaid world, or even with ACOs and things like that. So I think too many people are dismissive of it. And more often than not, payers were a little bit dismissive, right? Because they were focused on their margin. And the way they got to margin was really through prior authorization and that gatekeeping right up front. We know that's going away. And Neetu and I really see a pivot now to really looking at the cost of care, improving quality as a way of having a very stable health plan, having stable delegated entities. And we know that's more and more delegated providers are more and more taking root in the system. And there's a lot of economic opportunity for everybody, but there's also the opportunity to take quality seriously, improve results, lower the cost of care, and really move things back to primary care. That's where it should be. Too many dollars are spent at high cost settings and hospitalization. And some of these measures, like transitions of care and readmissions, really encourage us to be proactive and really reduce costs and improve outcomes for people. And I think that's what excites us about all of this.
I love how you're thinking, and I think it's so important, especially with a lot of the recent changes. Now, you mentioned Agentic AI. I'd love for you to talk a little bit about that, and then tell us too how Lilac is thinking about using that with what you said. Maybe you can illustrate it for us.
Agentic AI is all about doing things behind the scenes that don't always have to be done by humans and building plans and helping humans execute. So examples of agentic AI things that are currently possible to go do is think of all of the nurses and the pharma techs that have to like make phone calls to help with medication adherence. Before they even get to the making the phone call, they probably are talking to 5 or 6 different systems just to get their data in order so that they can make a phone call. And they're probably doing a lot of work prioritizing the list to make sure that they're calling the right members. They're probably collecting a lot of data to remember what the last several conversations were so that they can have this conversation that is relevant and contextual. You can use an agent to actually go capture all of that data behind the scenes, to collate it, to identify who's most likely to respond. Have they responded in the past? What is the best thing that I can offer this member? All of that behind the scenes prioritization, collation, aggregation, and collecting of data, that can all happen behind the scenes using an agent. And that's one portion of what an agent can do in terms of optimizing a workflow. The second piece is maybe not all phone calls need to be made by a pharmacist. Some phone calls may just be like, hey, Neetu, how are you doing? Can I help you with something? What is holding you back? And discovering what the barriers are. Those phone calls can happen using a virtual voice agent, as in, and then you collect that information and then you follow up. And the voice agent can actually remember, hey, last time we talked, you said you were having challenges with transportation. Have those been resolved, or is there a different one? There are tools and technologies available today that can streamline the work that people do by acting like assistants and data analysts behind the scenes. There are also tools and solutions available today that can make the simple phone calls, do all of the remembering. And the best part about it is you don't have to limit it to a small number of members. You can actually call literally everyone because the scale and the cost of these technologies now affords the opportunity to reach out to every member, to have personalized care for every member, to remember the care for that member over time. And Lilac is in fact building some of these solutions right out of the box. We're working on an HRA solution that can like immediately, as soon as a member joins a plan, we can outreach and conduct a health risk assessment, remember all of the things that the member needs help with, inform the plan to help them build a care path for that member. Similarly with medication adherence reminders, other gap closure reminders. So we're building these systems that can orchestrate, capture the data, make it very efficient for either the human or the virtual agent to make a phone call.
I think that's so important. And it's funny, I was literally having a conversation yesterday with someone, and we were just talking about, I always talk about people living longer, not necessarily healthier. And just looking at some recent data that came out from some studies that were done. And it's true. We know people are living longer, not necessarily healthier. But one of the things that I was looking at in the data is that chronicity has not gotten worse. So it doesn't mean that people are sicker, but actually the population has expanded, right? We have more people having the same types of conditions that the other ones had in the past, and you have the same level of prevalence, if you will, but you have just greater people. And there's this expectation, though, in our society, too, with having things that are personalized. And we were talking about exactly that. How do you, as a health plan, as another health organization, how do you care for all these people in a way that is meaningful for them and engaging them to get them to do the things that you need to do? And like you said, Marc, taking it back to primary and getting them to engage in appropriate ways. Would love to hear you talk about, because Marc, you brought up standardized data, and that would be my question, because working at a health plan and working at a medical group myself, that was one of the things, is that the data was never standardized and it was always a challenge. And even when we would use AI and NLP and all these different systems, we still didn't get all of the richness of the data that we needed. Talk with me a little bit about what you're doing at Lilac to help standardize that, to be able to get to what you were saying about that personalized approach in working with patients, especially knowing that we have more and more people to take care of today.
Absolutely. And I think that's one of the secret sauces that we're working on. And I know plans will say they're working on this agenda too, and that's great. But I think AI and machine learning and other data analysis techniques have come so far in the last couple of years. So we are really leveraging the most advanced artificial intelligence and machine learning to really think about data differently. When we go to a client, we ask for the current formats they have out there. We're not going to burden them with putting them in some really clean format that we've come up with and force them through hundreds of hours to do that. We're asking for what they use today. And based on some of the great connectors and other AI and ML work that Neetu's team does, is we are able to really recognize what that data point is and put it into a database, normalize it, and really make it actionable in data mart. So it's really a whole process of moving the data through, understanding what it is, and then creating those data marts to make them actionable in different areas. And our operational knowledge can do that in the quality area, in the cost of care area, in the member satisfaction area, really across the board for providers and payers. I think what is most important as well is we create a data rich environment. And so we're constantly learning from the new data coming in. So we're not just looking at it at a point in time and making a recommendation, but through AI and machine learning and agentic, we can actually gather additional information about the member. It can be from publicly available data. It can be from a health risk assessment regarding socioeconomic impact. It could be brand new clinical things that happen in terms of disease states or a hospital admission or an ED visit and things like that. And by bringing all that data together and actually learning from it each time, and then actioning it to the stakeholders at the health plan or the provider group is really the key to drive performance change and reducing costs. And the power of AI is such now that, as Neetu pointed out, it can be done cheaply, it can be done quickly, and it can be put in the right context. And that's oftentimes what providers and payers are missing. It's not in the right context.
Absolutely. And very astute. And I was going to ask you, and you mentioned a bunch of it. Where are you getting your data and how? What type of sources? Maybe you could share a little bit of the links that you go to get the data that you need so that you can come up with those insights. And then I'd be curious too, because we know that I use AI, and sometimes it comes back with things and I'm like, whoa, that's not right. And you have to check it. And so how are you getting the data? Where are you getting it from? How are you creating those relationships? And then tell me too how you're dealing with any of the hallucinations that are created along the way.
Let's have Neetu start off on this, and maybe I'll go a little bit into the compliance angle of AI, because I do think you're raising a great point.
Yeah, the data that we're using. So we have a comprehensive platform that is a HEDIS engine and a PQA engine. So we're able to consume data that is currently going into the HEDIS engine. So we don't ask plans to do anything too exotic or anything for us. We ask them to share a copy of whatever they're sending their HEDIS engine to send to us, and whatever their PBM is sending them to send that to us. So in which case we're able to consume all of the medical claims, the pharmacy claims, enrollment eligibility. And on top of that, we've built a full HEDIS engine and a PQA engine. Between both of those, we have pretty clear picture of where the membership stands, where the current gaps are. And then we have AI and forecasting on top of it to identify which measures are most likely to have an impact, which members are most likely to have an impact, who needs the most help, and also the longitudinal view of which members are in which measures across HEDIS and CAPS and drug measures. And we're able to make a clear plan of attack for those members. In terms of like hallucinations, our agents are very tightly guarded. They have conversations with members or providers that are very narrowly controlled. And there's a very strict guardrails around what they're allowed to talk about and what they're not allowed to talk about. Actually, here's a list of things they're allowed to talk about and everything else they're not. If you talk to our agents and ask them to give you any information outside of, let's say, in the HRA agent, anything outside of HRA, it will basically say, I'm not qualified to answer that question, and I do not have the information. Instead of worrying about all of the possible things they could say, we have very narrowly told them about, here's only the list of things you're allowed to say. What it does do is it allows the agents to have a pretty natural sort of conversation with members. So not every member, for example, is going to say, I don't know where my member ID card is. What are you talking about when you're doing a HIPAA? So that is a question the agent can answer. But if the member asks a question about, and I have a pain in my foot, what should I do about it? The agent will tell them to talk to a doctor at that point. So we've very narrowly constrained what sort of conversations the agents are allowed to have. So that's how we get around the hallucination challenge. And that's how we get around the going rogue challenge. We keep them pretty narrowly constrained towards a few things. Yeah.
And as Neetu noted, this is all about use casing the scenario, right? Our understanding of what needs to be done and how health plans and providers operate gives us the ability to use case it and create those guardrails. And that's just that's both an issue of not making mistakes, but also providing value and a return on investment as well. On the regulatory side, what's very interesting is we're actually pretty big proponents of the right regulation of artificial intelligence, because I think we bring an understanding of it. Many people will want to overly prescribe, which will stifle innovation. There are others that want it to be a wild west where, anything goes, which will create problems and backlash and things like that. We believe a risk-based approach to AI is very important. It allows innovation, but as the risk to the individual or to the circumstance increases, you have to establish greater and greater guardrails. So privacy, health, all those kind of things, privacy are just so critical with AI. And we really think through those in a very deliberate way with this use casing that Neetu talks about here.
I love that. And I'm glad you brought that up, because I think back to maybe, I don't know, what has it been, a year or 2 years now, where the health system was shut down for quite a few months because of a data breach. And then now, or in the last year or so, maybe others have been talking about it longer, but just AI and all the things that you can do with it. And like you said, the Wild West, and how you balance that I'm curious, maybe you talked about the things that you have in place to ensure that you have that balanced approach. Maybe you could talk a little bit more about that and then even how you're having those conversations with clients around privacy protections. If you see anything that's come out lately in regulations around privacy, or even if you could predict things that we might be looking at. Because I think even the latest with the government has been they're going to let things flow freely. And knowing our history and some of the things that we've had, do feel like and agree with you that there needs to be some balance. So would be interested to hear about the governance structure that you have, and then also to, like I said, conversations that you're having with clients and maybe where you're thinking things might go in the future and how folks might set themselves up to be safeguarded against any issues.
I'll start us off and then I'll let Neetu pop in. But just, I think there are two vital aspects of this. There's sort of the infrastructure compliance and privacy and all that safeguard. And that's key in and of itself. So the framework on that is things like SOC 2, it's ISO, it's high trust. All those things apply as much to the use of AI and keeping private all of that information, the analysis, the agentic cases and things like that. So that's key. So think about a cloud hosting environment, thinking about the security that you have to demand, and you're layering AI there. And there's a lot of people that are talking about very liberal, open use of AI. But in the healthcare world, it's got to be closely constrained and it's got to be in the right kind of secure environment. And then on top of that, Neetu is somebody that understands this real well, so I'll turn it up to her. But then there's this whole layer of compliance related to what should AI do from a privacy and just a information sharing standpoint. And again, I'll go back to the use cases before I turn it over to Neetu, but the use cases provide the guardrails to do that. So everything is in a secure environment. Then we place those guardrails for the use case. And the third point I'd make is we are having our clients sign off on every one of these use cases. They elect to do a certain use case. They tell us if you're getting into the bounds of clinical decision making. And that's the other safeguard too. It's the comfort level of the client who really understands, hopefully, the member and what you're doing the best. But Neetu, I'll turn it over to you.
Yeah. Shannon, you mentioned earlier about the deep empathy for the healthcare space that we as Lilac bring. And it's true not just in terms of the experience that Marc brings, deep healthcare experience, but it's also true in terms of the technical experience. That what Marc said is reflected all the way down to the tiniest pieces of our technical infrastructure. So, for example, we've chosen to build our platform in a way where everything is isolated. So every client's data is isolated into their own environment. We never share the data. We actually roll out separate environments for separate clients. And even the test and production environments are separate. So by default, the surface attack area is much smaller. So that's the first piece where we've isolated the client's environment, and then we have the highest level of potential security applied to those environments. The SOC 2 and HIPAA requirements are all the way down into the platform, even to the point where we don't store any data that we don't, like we just don't store it. And if we store it, it's under like serious lock and key with all of the modern security requirements and encryption requirements. And it's also true for all the way through like the BAA sign and requirements with any of the LLMs that we're using, being very narrow in the set of questions we're asking the LLM. So we're actually not sharing data with the LLMs if we don't have to, even though we have agreements that none of the data is used for any training purposes. So it is built all the way from inside out into the technical environment and also the infrastructure pieces and the coding pieces. It's just pervasive throughout. I don't think there is a way to do it outside of that. And then mostly on top of that, it's the individual use cases. If your use case requires a wide open question with lots of PII and PHI, that's a different use case than I'm calling you to remind you to pick up a prescription that I already have information about. I think there's wide variety of possibilities here. And like Marc said, there is real harm you can do to people with clinical outcomes, with providing clinical guidance. So we as a company have chosen to stick to the things that we do very well, and none of us is a doctor. So we don't do that.
I think,
Or medical doctor.
yeah, I think that's really important. And I know I've heard from others and been a part of conversations talking about you really do have to be thoughtful about how you're training your agents. Because if you pull in, and what we were talking about before, if you really want to be authentic and work with that patient of where they're at, someone with, say, the same age, gender, ethnicity in, I don't know, in Washington State versus Washington, D.C., even just those geographies are going to change who they are as a person. And so how you might deal with them might be different. And again, you're going to want to bring in data that would be specific to as much as possible, I think, address all the intersectionalities that go into who we are as people. So I think that is so important. You had mentioned, or you guys were talking about, and I have so many questions, so many places we can go. Let's talk about, we'll stick on quality, but I do want to go back to talking about cost and prior authorization and some of the things that you had mentioned. But maybe we could talk a little bit about quality measures and knowing that everything is required to be electronically reported, how you're helping with that. If there's anything there that you think, just knowing the changes that are going on in the industry, that folks should be aware of and particularly attentive to.
Marc, that's a good question.
Yeah, great. Yeah. So I think your Shannon, your point is really important. Really, though, where CMS is going and where NCQA is going,
Yeah.
and where the pharmacy world has already gone, really leading on interoperability and those kind of transactions, it really is meant to become all electronic. It does a couple of different things. It reduces patient error, which is dramatic in this country. It saves costs, and it provides an availability of data much quicker than you previously would have. So everything is going the world of electronic. Now, having been in this world for a long time, I know that this is not an easy thing to do, right? We are probably, I would guess, a decade away or more in billions of dollars in spending until we get to a truly interoperable environment. And we've had fits and starts along the way. But many people criticize CMS. I even have issues with it sometimes. But I think by and large, they've been a good steward of the healthcare system. They've created good quality programs that now have a very good interoperability agenda. It's not perfect, but it's bringing us in a way where prior authorizations can be real time. Data collection can be real time. We can intervene and care in real time between facilities and providers and payers and things like that. And hopefully over time, we will get a very robust health information exchange network out there. Some states do a great job, others do not. But that move to interoperability will be a game changer for health plans, for providers, for our healthcare system in general. When we get there, the ability to impact the cost of care and improve quality will be so much better. At Lilac, we try to fill in some of those voids right now, right? So on behalf of a plan, we're going to connect with an HIE or another provider or a facility to get real-time ADT information so that we can get it to the provider who may or may not be connected and inform them that they need to do a follow-up emergency department visit or a follow-up on an admission. Because again, all of that ties to readmission problems. It ties to chronic disease state, hospitalization, and things like that. And it's just a tremendous waste of money. Everything is going the way of quality, NCQA of electronic. NCQA is migrating to what's known as ECDS. You know, all of the interoperability standards for the ACO program and all the participation programs in quality in the fee-for-service program, all of it good things. And we're part and parcel of trying to drive that agenda forward, filling in gaps right now, but hopefully very soon being able to leverage this interoperable network out there that hopefully will be emerging.
Fantastic. I really do think the piece about the clinical and not letting the engine practice that is important, because there's a slippery slope there that we've seen happen in the past. And I think and some of us have forgotten the lessons, I think, because you do see it starting to go there as far as how they're making decisions around what's approved, what's not. And we tend to be an industry that tries to generalize or universalize our decisions. And that, again, that gets away from being authentic, individualized, and then in the end, practicing and doing the right thing. Is there anything that we haven't talked about yet that you've wanted to talk about? The conversation goes fast.
I think we've covered quite a few things that were top of mind for me. I think if anything, just want to really highlight like the way to take better care of members and patients is to actually be, like you said, authentic. And you
Okay.
can't fake authenticity. You have to know who they are. You have to have a conversation with them. And there aren't enough people hours to have those conversations and to remember those conversations. These are things computers and agents and AI do really well. We should let them do it. We should let them have the conversations, remember the conversations, have a follow-up plan, remember to call them at the right time at the follow-up plan, and not miss a date and not get sick and not have other pretty human challenges. Like these are things that can happen that we can just do with AI agents and having good data in place. And we should let computers do that. And this was one of the big reasons why at Lilac, we wanted to make sure that we had like full complement of data. We wanted to have patient level data. We wanted to build the measures ourselves so we can have a view into it in grave detail so that we could help people exactly the way that they needed help and at the time that they needed help. Super excited about that part where there is data, there is no lag in actual calculations, there is no making a phone call when it needs to be made.
Talk about that, because that's something that I think that is always a challenge, is the lag. Working on the MSO side, it was lag from the health plan. Patient gets upset because they had that colorectal cancer screening. Why don't you know that? Or the doctor, why are you telling me my patient needs that? Maybe you could talk a little bit more about the lag and expand on what you just said.
Yeah. Let's like build a chronological timeline that we've encountered a few times, right? Let's assume that your claims processor is super awesome and that you got your medical claim the same day as it happened. Like we can start with a super optimistic note, right? You got the claim the same day. That claim sat around somewhere, and at the end of the month, it got packaged up and got sent to the HEDIS vendor. Then it took another month before all of the information from the HEDIS vendor came back. Then it took another 3 weeks before the chase list got separated out for the different measures. And then probably another week before it got separated out for the different provider groups that need it. So now the claim that came 2.5, 3 months ago is represented in a chase list 3 months later. And then it probably took a week for the doctor's office to look at the chase list. And then it took another 2 weeks for actually making all of the phone calls that needed to be made to schedule appointments. We are now talking about a 3.5, 4 month lag. And what happened? With Lilac, that gets dropped down to as soon as you can give me the HEDIS data. Like The claim comes in, you have a package, or just give me the original claim. I'll take the original claim. But like for convenience sake, that we do the HEDIS data. The minute it goes into the platform outcome chase list at provider level immediately, and they can immediately, an agent can pick them up and hand them over. That took maybe a few days. So now we're talking about something that used to take 3.5 months just to cause member provider abrasion, to now cause something that is fast, that providers will actually find helpful and members will actually appreciate, because I think it's reasonable to assume it took a month. And that can also be cut down even shorter. It is not true for pharmacy claims right now. So that's medical claims. Let's talk about pharmacy claims, right? It's the beginning of the year. You're already prescribing multiple drugs. People are taking them. There are poly-ACH and CRV measures that pharmacy data is going to Acumen, and now you're waiting for the results from Acumen to figure out who is actually at risk. It's 6-8 weeks into the year. Some of the numbers have already been like in that measure for more than 30 days. You've lowered the ceiling for where you can get to just because of data lag. We're not even talking data quality. We're not talking running of measures. We're not talking outreach. We're just talking data lag. That's like another thing where with the Lilac platform, we can take pharmacy claims data that your PBM is giving you every day, every week, and within very near real time outcome chase lists, not just chase lists for medication adherence, chase lists that are prioritized for who to reach out to about what. And it's not just for the measure. This will, like, patient safety measures aren't just to hit the measure. It's because it's actually dangerous for people. So just by removing data lag using tech, you may have actually saved people's health and helped them measure. And if you then automate that outreach with a voice agent that never forgets to call and is never sick and knows exactly all of the information about you from the past outreaches, then you've done like much, much more precise outreach. So not only did you save on like cost of doing that outreach, you changed the game. You changed the game in terms of who you can outreach. You change the game in terms of how fast you can outreach. You can change the game in terms of a follow-up call. Okay, Neetu, you can't talk right now. Okay, can I call you tomorrow? And then you call them tomorrow, right? I think you've changed the conversations you can have, and this people's lives on the other side. This deserves it. If not, what this is the thing that feels like the most valuable problem to go solve right now.
And
Go
Oh,
ahead, please. Yeah,
yeah, I was
please.
just going to say, Shannon, just to touch upon sort of real life circumstances here. For the first time, CMS has put into the STAR program 2 what I call patient safety measures that Neetu talked about. And they can be debilitating if these aren't managed to a member, and they create so much cost in the system. One is concurrent use of opioids, which are needed to some degree, and benzodiazepines at the same time. We know that the interaction of opioids and benzodiazepine have real implications, especially for senior populations, right? So for the first time, they moved it from what's known as the display measures to the true STAR measures, and now they're rating on them. And then the other one is multiple uses of ACH drugs. I'm not going to say the name of it because I'll butcher it, but there's a whole bunch of drug classes that qualify as these ACH drugs, and they have some of the same implications for senior safety, cognition, falling, things of that nature, which really are big issues within the Medicare system. So making sure that people don't abuse these drugs on purpose, perhaps sometimes, or by accident, because prescribers aren't being coordinated. Oftentimes you find a person with maybe some slight dementia or some cognition issues, which is not reporting to all of their doctors what drugs they are on. And because of missed handoffs, you don't always know if there's concurrent use of some of these drugs. And so that's really where these measures go. But they promise to better health, reduce injury, and reduce cost in the system. So these are the kind of things that make a great deal of sense that we have in our system. And there's other clinical examples of that too, that the quality measures monitor too.
I love those examples. And I can tell you from being someone who was a leader in operations working on these types of measures, just some things witnessing where there were these all universal general strategies where in the instance of those medications, they just deny them. Some people actually need them. And not just those medications, we could talk about lots of different things, MRIs and whether or not you got referrals. And the thought has been, we'll just deny everything and make them appeal, and then we'll review it then. To your point, now you've slowed things down. And then also, too, when we talk about just dealing with people authentically, we're not. And then also, I think one of the things that's important is trust in the healthcare system and people feeling you actually are aware of what their needs are, and not just patients, but doctors too. Because I can remember being in those conversations or being the receiver of that data that was 4 months old. And it was like, where did you get this from? I don't have time to mess with this. I'm busy taking care of all those people that are living longer and not necessarily healthier. So yeah. So how do we, I don't know, how do we attend to that? And I love that you guys are able to do that. And I think that those are excellent examples. All right. We've talked about a lot. I think there are so many more things that we could talk about around cost containment, because I think that margins are very slim these days and folks are struggling to determine not only can we have specialized plans, which when you think specialization, you think costs go up, right? So not only that piece, but how can you really get at managing members well? And I know that you gave us lots of great examples. I don't know if there's anything else that you guys want to talk about or mention today that maybe we didn't have an opportunity to get to.
I might mention the recent PricewaterhouseCoopers study. It's a
All
bit
right.
of a blockbuster. And
I think I
in many ways, we think Lilac is part of what they're predicting. PwC is predicting that by 2035, about $1 trillion will be spent on what they call agentic AI, personalized care, and things of that nature, digital health, just really massive engagement of members to better outcomes. And I think they're right about this. I think technology is going in that direction. I think we're at the start of that as Lilac, and we're part of that process, as I noted. But it really does hold great promise because it holds great promise from what you think of as true evidence based scientific personalized care, gene therapy, and things like that. But it's also what I think of as what I call a model of care for everyone. Everybody, regardless of how healthy they are or not, everybody needs a pathway and a journey. And I think technology can certainly help create that personalized pathway and journey. And especially as boomers become much more technology literate and as more generations age, for example, into Medicare, where costs go sky high, these technology investments are absolutely critical. So we shouldn't be afraid of them. And so I think PwC is right. It's going to be about $1 trillion. It's going to be about 10% overall spending. We shouldn't be spending that much, but hopefully that $1 trillion over time can reduce overall costs too and bring those annual increases in cost down too.
I think most things health plans do are the exact right things to turn into agentic workflows. Like almost everything can be agentic workflow. Future is definitely agentic.
I know we've talked about a few. Do you want to mention a couple? Maybe there's some additional ones that I think they should.
There are so many examples. Definitely keeping track of where all your members are, what they need help with, when to outreach to them, like keeping a pulse in check to make sure your population health initiatives are making sense, CAPS surveys on a regular basis, pulse surveys on a regular basis, utilizing that information to drive things. If you're doing HRAs that are agentic, you have structured data that you can directly flow into a care plan. That is definitely agentic. I could just go on for the rest of the day.
Let's do this because I know we've talked about a lot. If folks wanted to find out more about Lilac and talk more with you, what would be the best way to get in touch with you?
We are on LinkedIn. We have a website, lilacsoftware.com. My email is neetu@lilacsoftware.com. I would love to talk to anybody who is passionate about this. I'm very passionate about it.
Awesome. And we'll include links as well in the LinkedIn post. So glad that you both were giving of your time today. Definitely have learned a lot. And like I said, I'm in the day-to-day. I'm going to be at a conference next week talking about benefits and product design and how do we make sure that we're designing the right plans for the right patients. And we were having these conversations about how do you manage costs, but still provide that individual plan that folks need, and then do all the other things that we need to do in healthcare, knowing that just the volume of patients are increasing. We know the amount of physicians out there, primary care is decreasing. And we really do have, I think, that cliff moment, if you will, that's coming upon us in healthcare. And Lilac has done a lot to help with that. And so I'm really excited to get to share your product and your thoughts with the audience today. And again, just want to say thank you.
Thank you for the
Thanks
opportunity.
very much. Thank you, Shannon.
Awesome.